to our Friday morning meeting, which this week is hosted by the Department of Medical Care, and we're privileged to have Prof speaking to us. I'm sure he's well known to everybody, and I'm sure you've all read the bio as well. But just to mention that infection and sepsis in the ICU is an interest and perhaps a passion of Prof Mer's, and so he's going to talk us through the fundamentals of sepsis in the 21st century.
Thanks very much, Sarah, and thanks very much all of you for being here this morning. We thought that a topic like this would be really relevant. Number one, it's a very nice way to collaborate, and I think it's something that crosses all domains. It doesn't really matter what our background, definitive interests are across the domain, whether it's immuno-oncology, whether it's infectious diseases, whether it's maternal medicine, whether it's gastro, whether it's renal. Across the spectrum, this is a really, really relevant entity. So, you know, it's certainly my own scientific stimulation was very curious for some of the fascinating talks we've had over the weeks. But this comes down to some of the bread and butter issues, and hopefully we can put the elements into some sort of perspective. I don't really have any disclosures at all. I think, as many of you know, since just before the pre-COVID pandemic, virtually every single day has been spent in hospitals. I've really not had much of an opportunity to do anything else. In the next short while, we're going to go through a couple of entities, and we're going to keep it very basic, bread and butter issues. Sepsis and septic related entities really entail a full-on, not just a workshop, it's a day or two entity, and each of the definitive elements themselves could really manifest for several hours of discussion. So we're going to chat about definitions. We're going to look at some of the sepsis facts, which I think are frightening and often not recognized. We're going to touch on a very important element for the Surviving Sepsis Campaign guideline, which is a global guideline that is essentially the Bible of sepsis care. We're going to touch on some of the integral components of management that I think are really important, the principles that we all have to take out. We don't have time to address all the others. We're going to touch very briefly on an entity called the 1 hour bundle. And we're going to look at the very latest Surviving Sepsis Campaign guidelines, and we're going to back out elements from those that are both new, that are novel, that have applicability in our setting. And then we'll look at components of those guidelines and what other recommendations there are for people like ourselves actually practice in resource limited settings. We think that we often delivering state-of-the-art care, but if you go just 5 kilometers from where we currently are, you wouldn't be something as that. And then we will conclude. So a very important issue to understand is really what we mean by sepsis. In 2016, there was a new definition. A group of people got together and put together a new definition in terms of what we actually understand by the term sepsis. That's called the Sepsis definition. And in fact, the group was led by Mervyn, who's a physician in intensivist at University College London. And was not aware. We mentioned his name many, many times. What we mean by sepsis is that it's a life-threatening organ dysfunction caused by dysregulated host response. That is the definition of sepsis. So you get an infection, you mount an immune response, your body tries to protect you. As a consequence, you can then have a organ dysfunction. When that moves along the spectrum to create septic shock, which means you're hypotensive and you've got an elevated lactate, that organ dysfunction becomes a life. And that's what we mean by sepsis. It's a term that's bandied about, but often not understood. So in the last year or two, having a massive interest in this. In fact, this is what I put together, which I think you'll see in many of the new global guidelines accepted as a very simplistic issue. You have an infection, you get a dysregulated host response as a consequence, organ function may occur. That's potentially life-threatening. That's what we allude to as sepsis. So let's take a step back and let's have a look and see how significant this problem really is. Because when we look at what the knowledge about it is, we would be very, very surprised. So, as far as we currently understand, this is a gross pandemic. There are at least 50 million people per year afflicted by sepsis. Even amongst those 50 million people, 11 million people died. We're going to put that into some sort of format so we can really understand the magnitude of this issue. If we all worked in an ideal setting, only 10 to 30% of individuals actually have access to excellent care. And the best medical centers in the last 5 to 10 years have possibly doubled your chances of survival. And what that means is that you have septic shock and you land up in the best center with the results in space. US in New York, you have an 18 to 30% chance of survival. If you in fact, in a country like ours, or if you're in a veterans hospital in the US, or if you're in a routine hospital in the UK, that number is substantially greater. And in fact, there are 2 bits of excellent evidence that have just come out. One was a paper I was fortunate enough to be asked to review from Kenya, where the practice is very similar to ours. Academic, major mainstream hospital, 83% mortality for septic shock. If you're in North Africa, from Tunisia, 85%. So there's a gross discrepancy depending on where you're based. And the sad issue is that most of the studies that have been performed within the context of this particular domain have been formed and developed and studied in the developed world. And that for me is a huge problem, because what is being forgotten is that the vast number of people in this world live in resource-limited settings in low-income countries. In fact, if you look at the world population, just 15% of people live in high-income countries. Yet all the guidelines emanate from them, they're not necessarily extrapolated into our settings. If we look at the numbers of sepsis globally, 85% of all sepsis cases occur in low-income countries. And if we look at public awareness, it's extremely poor with respect to this particular entity. So if we take a country like Australia, where everyone has tertiary education, literally, and we deem that people have had a very good background in terms of schooling and so on, in a recent survey, just 40% of Australians had ever heard of the term sepsis. And in and amongst that group, just 14% could mention one symptom. If we correlate that with a country similar to our own, Brazil, frighteningly 7% of surveyed people randomly had ever heard of sepsis. And in fact, when they started a massive initiative to educate people, the very latest data from them is at just 14%. That's a country very similar to ourselves, where there have been massive educational programs regarding sepsis in the US, in the UK, and in Germany. Those numbers respectively are 55%, 62%, and 69%. So where people have had formalized on TV, on radio, where there are programs that are out there, at very best, 2/3 of people have ever heard of sepsis. There are long-term sequelae. It's not an acute problem only. In fact, quality of life is impaired if you survive. There are increased hospital readmissions if you survive. There are increased cardiovascular entities if you survive, and most frighteningly, if you've had a single episode of sepsis, there's an increased prevalence of cognitive decline over time. For children, and that's a really important issue, sepsis accounts for 60 to 80% of all deaths. Frightening. And if you survive your episode of sepsis, you double the risk of chance of dying in the next 5 years. And so these are things that we have to start taking cognizance of, particularly where we practice, and particularly bearing in mind that in a country like South Africa, where our average age of the population is 27, okay, we're on this continent, by the year 2100, 1/3 of the world's population will be on this continent. If we don't start doing things about entities now, we're going to be in big trouble. So I want to really put this into perspective, because every time I look at it, I take a deep sigh. 50 million cases minimum, that's from a registry. That's far in excess of it. One person dies every 3 seconds. That means for every minute of this talk, there's nothing right there. Absolutely nothing. We've spoken about the lifelong consequences, and as we currently understand, if we took all deaths in the world, 20% of them are wherever you are. These are really frightening statistics. And in fact, there's been a lot of pressure that's been brought to bear on large bodies to say we need to estimate the relevance of this particular entity. And so a couple of years ago, the World Health Assembly, which is the mouthpiece of the WHO, passed a resolution stating that we've got to improve the prevention, diagnosis, and management of sepsis. And that went out as a formal entity, but you've got to implement it. And that's the huge problem. And in fact, there's been a very proactive body that's relooked this. I was fortunate enough to be party to that, and the WHO has just come out with a new resolution in the last few months regarding that. One of the entities that I think has made a massive difference to everyone and anyone, whether you have an interest in the field or not, is the guideline, which was initiated in 2002, and there have been 5 iterations. It takes 4 years to put 1 iteration together. That is all the data on sepsis in an evidence-based fashion with appropriate guidance. And previously, it's been a European, North American entity. And for the last iteration, in fact, I was fortunate enough to be asked to be a panel member. It was the first non-American, non-European individual. And in fact, for the new iteration, in fact, I'm one of the 6 guideline leaders and the only person out of North America and Europe, which is important for us because we can at least try and push entities that are relevant outside necessarily of high income settings. So what are the integral components? I think the first important entity is to recognize that sepsis is a medical emergency. We talk about time to muscle bars, time to brain, the CBAs, but we forget about the issues here. The number of people that lie around in casualties and elsewhere, all have delayed presentations infinitely on time. And so we've got to recognize early, we've got to be appropriate with our management if we want to improve outcomes. And so if you forget anything from this, remember the following. There are 3 important pillars that we need when we're evaluating patients for sepsis and septic shock. And you can take all the guidelines in the world, but you pluck out the elements that are relevant that pertain to the following issues. And there are 3 of them outside of recognizing the problem. The first is early appropriate antimicrobial. We'll chat briefly about what we mean. The second is restoration of adequate cellular perfusion. I see Kelly after a long night in isolation. but after resuscitation, that means fluids and appropriate vasopressor support. And we'll tell you about simple ways to monitor that. And the third and most important thing entirely forgotten is so-called source control. And it's not really our advice of what every single day. You can have the best antibiotics, you get the best fluids, you can start the best vasopressor support. You don't deal with the primary issue. And then we need relevant supportive care. And very importantly, because of these long-term sequelae, we need post-sepsis care as well. So very simplistically, if we look at the middle bar there, we need to have a high index of suspicion, confirmed suspected infection, and that means in our setting, excellent clinical acumen, together with targeted laboratory and imaging entities. It's fairly simple. There are also a host of scoring systems that can assist us. And then our focus must be on organ perfusion, which is an immediate priority because that is what's going to save the person's life. And infection treatment, and their two components. It's appropriate antibiotics and its appropriate source control. So to try and put this into a very simplistic issue, the Surviving Sepsis Campaign guideline came up just a couple of years ago with what they called a 1 hour bundle. They gave 5 different elements that they felt people should proceed with. In this sense, that's going to be being superseded. But one was obviously gets to the patient with either suspected sepsis or confirmed, measure blood lactate level. But the problem is not everyone has access to lactates, which is an entity. You're in big trouble if your lactate's above 2. 2 is to take blood cultures. 3 is to administer upfront in the appropriate setting, antimicrobials, always to begin resuscitation. And that suggested on average, with 30 moles per kilogram of fluid the first 3 hours. And I think there are some elements, particularly if you are hypotensive and your lactate is above 4. And then if you're not willing with that resuscitation, to add vasopressor support and to target daily blood pressure of 65. Doesn't matter what you dermatology, if you endocrinology, if you ICU, it doesn't really matter. And there are a number of entities that again underpin this, the importance of getting in early, the importance of changing outcome. And if you did this, in fact, this has been validated, it definitively changes outcome. But there have been advances, and the latest iteration of the Surviving Sepsis Campaign guideline, in fact, is about two years old, essentially. And there were some important and valuable new entities that came through. The particular guideline, I think, was a significant evolutionary one. It was more diversive and really aimed to foster good clinical practice and was potentially adaptable into the setting of low-middle income countries. And I think if we have a look there, and I've just summarized the important domains that were looked at in this context, and 93 statements were made. Now, each one of those 93 you could spend several hours with. And we're just going to try and, we've already shared the 3 important pillars, but these were the entities that prevailed. And what are some of the new aspects of interest? And one I think that is massively important is you can use peripheral vasopressors. That's a massive new advance. And the rationale for that is so that we can get on top of the blood pressure issues, restore perfusion early, so that we're not waiting. So it is acceptable now to put up a peripheral line and give vasopressor support. And the issue then is that should be proximal process. Pick up a big vessel there, you can put it in, and we now know the evidence that is out there is that you can do that for 6 hours. So we were actually people that South Rand at birth or wherever, and you're in trouble. Put up the peripheral line, you can start your vasopressor support together with your fluids, and you can in fact change the outcome of patients. Corticosteroids have been a big interest in this unit and in this hospital, and in fact, we were the first people in the world to advocate the use of corticosteroids in the human setting, in animal data, and in the human setting. And in fact, what emanated there was everyone going like, so for many years, been trying to change that because that is the incorrect dose. The correct dose is 200 milligrams. That's the evidence base. That is what we currently do, and the guidelines suggest that you can add, following your appropriate resuscitation, including fluids and vasopressors, if you're still hypertensive, hydrocortisone, if you're on vasopressor support, and more epinephrine, more adrenaline is the agent of choice in our setting. We only have adrenaline maybe. At that we have access to more adrenaline. If your value of infused your adrenaline is more than 0.25, you can utilize the same for adrenaline. Personally, we don't wait. You've given more fluids and you've started vasopressor support, you're not going to reinitiate the studies up front. And I think that is the way to go. Capillary refill time, something we all have access to, can be repeated as often as you want and costs zero, costs nothing. It's as good as lactate. It's an adjunctive measure of perfusion, and it's what we should be doing to help guide our resuscitation. And then another very important issue is we should all be aiming to get patients where it is available into the ICU within a 6-hour time frame. That should be the NC. So if we have the beds, that would be absolutely brilliant, but that is not ideal. The longer you leave patients out of an appropriate setting, the worse it is. What about antibiotics? And there are a couple of elements there. When should we give them? How should we give them? How should we make sure that they're working most efficaciously? And then in conjunction with them, source control, and how long should we give them for? And I think there's some really fantastic stuff that came out. I think this sort of stuff is simple and it gives direction. The new iteration, I can tell you, some of it's going to be mildly changed. But I want you to look at the two blocks. Where shock is and where shock is absent, and then where sepsis is either confirmed or probable, and where sepsis is possible, because that's the reality of what we deal with every day. So if you have sepsis that is confirmed or probable and shock is present, you get the antibiotic straight away. That has been trying to change. Ideal setting around cultures beforehand. And if sepsis is possible and the patient is shocked and you're still thinking this is likely to be get that antibiotic, and you can always stop them there. If shock is absent, you should work out the patients. That includes thorough clinical evaluation, appropriate early laboratory or imaging that may be relevant, simple things that can be done. And then, based on current evidence, you have 3 hours in which you initiate antibiotics. So I think this is really, this particular slide, just in general antibiotics, I think is crucial, absolutely crucial. And this is a landmark study. In fact, it's the most widely cited paper in the whole of medicine, clinical medicine. It's Alan Kuma's paper, and you can see it's close to 20 years old. And this showed in a multi-thousand patient population that if you have septic shock, for each hour of delay that you do not initiate antibiotics, your mortality increases by 7.6%. So can you remember at night, if it's midnight and you arrive at 7 in the morning to do your round, the patient's been hypertensive for 7 hours, you're starting off pretty much at 50% chance of increased mortality. If you get it in within the first hour, the chance of targeting the patient's 50%. So these are very important core principles that are absolutely essential. Just in terms of other new things, vasopressors, nor epinephrine, nor adrenaline is the agent of choice for vasopressors. No question about it. It's too costly in many instances for us, so we use adrenaline, which costs nothing in this country and is more expensive actually abroad. More expensive. Raw adrenaline. In many other countries in Africa, raw adrenaline costs nothing. So maybe we actually need to get a constructive view to reload these sort of entities, but we find it very useful. Ventilation, I'll touch on that. Because ICU follow-up and care is essential. Even in the setting of palliation and other sort of entities, because there are things like cognitive decline and massive diminution in quality of life. So just a couple of aspects on the fluid, which are very controversial because the guidelines say 30 mL per kilo. So most patients who present with significant sepsis or septic shock are all going to be hypovolemic. And that's because they have endothelial dysfunction and they leak. You get significant interstitial fluid accumulation. And I must say, I have taken on the elements of the 30 mL per kilo. You can see in the new iteration, that is probably still going to remain because there's great observational data to support it. But there are nuances to it. In fact, two brand new studies, and those who follow the CMJAH would know the classic and Clover study in the last year, show that giving too much or too little actually doesn't impact dramatically. And so, return on that, I'm going to try and push here, is that there needs to be focused here. That's the thing. Here's clinical acumen. We can all evaluate. I'm going to really we've all come through a system where we can evaluate the gender. We can listen for reality. We can listen for fine, late inspiratory practice. For those of us who do not face our objects and not putting something, don't need that. So we can look for beelines on the chest. We can teach people to do that without any problem whatsoever. What's really important is people flood fluids in without recognizing there's a lag phase. And so what that means is you should be bolusing patients. And a bolus doesn't mean 500 mL, 1 liter to pour in. It means 250 mL. And then wait 15 minutes. Doesn't ask you to tell you this. Because there's a lag phase to achieve homeostasis. And then you will determine if the patient's fluid responsive. You can repeat that to the people, and eventually you can get to what ultimately often will be that 30 mL in the first 3 hours. You can give it back in maintenance. Continuously reevaluate, and the ideal way is to do it with dynamic maneuvers. Those are things that we most frequently have in our sleep. It may not be readily available to everyone. Looking at pulse pressure, how should we give the fluids? And you're going to see in the next iteration, which will be published in 2025, 2026. I think I've almost accepted an MC that I've put forward. And that is, you administer fluids to see you have a decrement in measuring that for your very lethal time, such that your perfusion is improving. You don't administer the fluids until you've got full lactate mobilization. That's when we can grant the team to come and analyze the patient. That's a very important issue. Clinical acumen, really, really, really important. So, what fluid type should we use? Crystal wood. Which one? Balanced solution, ringers, modified ringers, Balsol, plasma B. That is where the evidence is will go. The so-called normal saline, which we sometimes refer to as abnormal saline, has been shown in a big resilience study now, 10,000 patients. We have that. It costs much less. So whatever, crystalline, ideally balanced solution. You need to resuscitate early. If you beyond the 3 to 6 hours, you lose responsiveness. So this is why it is an emergency. Synthetic colloids and starches we avoid. That will please Graham and the BNT committee. For many reasons, they're costly. There's renal dysfunction that's been associated with certain coagulation-related problems. And perhaps something that won't please Graham much is the use of albumin. I mentioned in a resource-limited setting, this is an ideal world where you pour into the patient's blood. It's a very useful agent for small volume resuscitation. Doing small volumes, maintaining a very good intravascular oncotic pressure, you keep fluid in the intravascular compartment, but we are limited, and we recognize it. We've spoken about vasopressors. Start early, don't wait. And in fact, what we want them to do there is restore adequate perfusion so we can reverse the hypotension. We've spoken about the options that we have in our setting, which costs about $1. Costs absolutely nothing. What should we be targeting for the general audience? The nuances. When you get a patient like this, target a mean arterial blood pressure of 65. That's what you should target. You'll see in the new iteration various other. This is just really a recap of it. I want to touch on this because I think it's one of the most landmark studies, irrespective of whatever domain or field we practice in. And that has come to the fore in the last few years. It's called the Andromeda Shock Study. Glenn Hernandez, who's a Chilean, absolutely brilliant guy, and he's just reached out to us. It's the Andromeda Shock 2 study. So it's nice that people are actually recognizing what we are doing. But this, in a nutshell, demonstrated that capillary leaking times that we can all do are as good as we can. It's as simple as that. And this is a case that those from the ICU would remember. A lady we admitted with a systolic blood pressure of 50. Let's see if this will play there. Full time. That's when she came in. We targeted our resuscitation to capillary refill times. Look at this. Patient went on. Patient went on. Simple, cost nothing, and repeat it as often as you want. Helps you guide your resuscitation. Remember the patient and this. So another very important issue, I think, is source control. And we don't have time to go through all of these things, but every single day, you walk through our ICU at the present moment, you will find a patient with literally every single one of these. So having that, you've got an advertising case in the unit. Part we've picked up ourselves and cardiologists, I'm sure, recognize endocarditis. It's big vegetations that you need to address. Intra-abdominal sepsis is a pandemic in this country. Skin and soft tissue infections is not a week that the literally goes by when we don't have the or some other issue, and so on and so forth. We've got patients with CNS-related problems, the chest issues are self-explanatory. We see a lot of prosthetic and other joint infections, and we see massive sepsis as well. You have to control the source, and you've got to evaluate these entities. And again, we are sometimes hamstrung because we don't have ready access to theatre. It's an issue, but then you intervene with other MCs that could require and make a difference. You can drain percutaneously, you can do local issue, you can put in an intercostal drain, often of which these things are missed. And one of the other reasons why we should have on site all the time an invasive radiologist in this country. So what do we mean by source control? It's an absolutely key and imperative principle. It means you drain any abscess, you debride any infected necrotic tissue. You remove devices that are infected. In fact, we just had a patient that was admitted with a staph bacteremia, 17 days. That patient died. Never happened. Definitive control of source of the ongoing I always use the term, if there is pollution somewhere, the solution to pollution is solution. Got to get rid of it, you've got to irrigate those sort of areas. Always culture, very important, so we can direct appropriate therapy. And timing is relevant. Until the last year or two, people didn't know when you should best do this. But for some of these conditions, we now have excellent evidence-based data. And there are landmark studies. I won't worry you with them, but these are just some of them. And the bottom line is you've got to do it, particularly if there's abdominal or necrotizing infection within 2 to 6 hours. In fact, this study is one of the best studies I think published in clinical medicine, demonstrated if you did not do it in that time frame, it's 100%. So we have fabulous information now in terms of what we should be doing. And I've been had the absolute privilege to work with Martin Johnson. Those who follow this field, you might be familiar with the name Jean-Louis Vincent, the father of acute medicine. And Martin Johnson is the next father, young, absolutely 20 or 30 New England Journal publications, about 400 or 500 others of a similar magnitude, published about 40. He's just a phenomenon. And privilege, this chapter is going to be published shortly. It is going to be, I think, the guide for what we should be doing. And in that mention, inability to achieve adequate source control despite rapid resuscitation and initiation of appropriate antimicrobials may result in failure to obtain clinical stability, assisting patient improvement, and that's entirely correct. All our efforts would be futile. And this is an example of what normal sepsis. We don't have source control. We get more and more antibiotics. We change intestinal flora. We get resistant infections. Bad doing, we develop tertiary peritonitis, poor healing, and it becomes a vicious cycle. And we block beds, and the patients become a problem. These are real issues that from the ICU. And unless we have addressed these things adequately, these patients will die. This is a patient we admitted some weeks ago. Had wanted to ablate his arm. Patient was ventilated here at Florence. Septic shock was resuscitated, as we mentioned. And in fact, he was an IV drug abuser, someone who's so permanently at the moment. We even woke him up from the ventilation to get his permission. He was no access to him. And he said that I'm on my own. And we put him back to sleep. And he was right. Patient was right. So we deprived him and he survived. And he would have had his arm taken off. It was an excellent degree demand. This was the patient. Condition that we call pancreatitis. Just antifungal therapy, but what we did is actually remove all of his face. And this is my left ICU. And obviously the issues are really thereafter hugely problematic. This was an awful case something from one of our cluster hospitals with an abdominal problem. And the abdominal problem was sorted out, but she had an ongoing pyrexia within a day or two. When she arrived, she had her arm bound in a tight bandage. Remember, one of the tight bandage, the floor of necrotizing fasciitis, or a peripheral line. She was a domestic worker. She lost her arm. She's right-handed. These things are not necessary. You can avoid all of these things. And this was the initial degree of a septic technique, really important. And something that, in fact, I spent many sleepless nights over, in fact, and wondered what we would do. You can see, this is the true South African scenario, old ventilator. Patient with a condition we not infrequently see in the public. He had limbs that were not viable. Eventually, we had to amputate. his upper limbs, and his lower limbs. And in South Africa, there's nowhere to place a patient like this. So we salvaged a young boy who's a teenager and subjected him to life. Much of this could have been avoided with the onset issue. We are only facilitators. We can facilitate a lot of good things. Lastly, there are a number of core elements of supportive care that are really relevant. I'm not going to take you through each of them. This is just a little summary table that's going to come out of this chapter. We ventilate non-injuriously. We involve excellent renal problems when required. Nutrition means you start in 24 to 48 hours. We start with the lower caloric intake. Glucose control in 2024 means a value of less than 10. We no longer have time for glucose control. We give everyone venous thromboembolism prophylaxis. If they're not amenable to it, we use mechanical devices. We transfuse. In general terms, if your hemoglobin reaches the region of 7 or below, they're cardiacs, we tend to have a higher threshold. If they're elderly, we have a higher threshold. We no longer flatten our patients. We use analgesia, we use analgesic sedation, very few patients requires ongoing significant sedation. Neuromuscular blockade only gives the symptoms ventilation. Stress ulceration only in select cases. Not everyone should be written up for painkiller. Patients who are hypertensive, who may be coagulopathic, who may be receiving dialysis, or who are hypertensive where they can hypoperfuse. Corticosteroids we've spoken about, positioning the patients relevant. Keep them up at 30 to 45 degrees. We mobilize our patients all the way to come in the morning, try and get all of them up into chairs. Doesn't matter that you're on the ventilator. Then psychological support is infinite. It's really relevant in the context of things. There are resource guidelines that are out there, again, started by Martin Lewis in 2012. And in fact, I was involved in putting out several of these that actually were put out. They're fantastic. It's actually available in the book form for free now. These are all published in high journals of intensive medicine. And in fact, looking at all of these, and this is resource limited focus. It's been downloaded when I last looked, and that was months ago, 125,000 times. So, how can we conclude it? I think sepsis and septic shock are common. In fact, in our practice, one of the most common thing that we can see. The absolute medical emergencies. We've got to promptly identify the high index of suspicion. Appropriate management definitively will improve outcomes. And the pillars upon which we must do that, outside of recognizing early appropriate antibiotics, restoration of cellular perfusion and source control. If you take out just those three things, you're going to change the outcomes. Relevant supportive care is important. So I will leave you just with one entity that I persistently find share. You do the simple things well. So I'll leave it at that. This is just a very much about the issue. It's a 3-day workshop. Essentially, but hopefully it's given you a little bit of food for thought. More importantly, hopefully will impact on what we go out and do. And thank you very, very much for your attention.